some of the opioid funds. And so obviously a lot of what we talk about ends up being about opioids. And I don't want to make this talk something that's not pertinent. And what we've been discussing within our group is that the CDC guidelines with respect to opioid prescribing are really translatable in more ways than we think into all the other kinds of medications that can lead to difficulties. And I want to try to emphasize that if we understand what the CDC is telling us with respect to medications that are inadvertently poisoning people in the US, we can prevent that with other classes of medications that have many of the same risk profile and the same techniques and the same recommendations that they give for the prescribing of these opioids translates into better safety with other agents. So with that in mind, what I'll do is just go through the recommendations with an eye towards how a population can be benefited from paying attention to this, because the concepts are so translatable. As we know, make sure this is advancing. There we go. So the CDC clinical practice guidelines were first created in 2017, and they were specifically revised in 2022 because of inadvertent problems that were developing out of misuse of the recommendations and misunderstanding of the recommendations. So there's been a lot of back and forth. You'll hear people kind of casually complaining about the recommendations, and I think fundamentally they're not understanding what's in them when they do that, because when we break them down, they're very evidence-based. They're very well done with respect to inclusion of groups and the concepts that they're getting forward with respect to risk reduction are, as I say, pretty universal and translatable. So they're really a tool that we can use if we understand what's going on. So with the CDC, they're tasked with prevention of complications and illness related to illnesses, not directly as the FDA would be, but basically they're fundamentally looking at the disease side of this and how to manage adverse effects from that standpoint. And so the development process was very unique. They looked at, they got the scope of the audience. They reviewed the literature that was available. They went out and got public engagement, and then with that, they made some peer review changes and came up ultimately with a set of recommendations that, again, are very generally universally effective. The regulatory environment for opioids is present for, or we should say medications for abuse, because it's not just opioids. It includes muscle relaxants. It includes sedatives, hypnotics, Z drugs, sleep drugs, and all those drugs that can specifically be problematic for an elderly population as well as an infirm population. And the guidelines first came out in 2016, and they were universally misused. Many of us are familiar with the concept of deprescribing and how because of insurance companies, because of policies within health systems, because of individual concern about risk of prescribing, we had kind of a wave of deprescribing and all the complications that occurred with that. Fundamentally, individuals using medications in ways other than as they were prescribed. So the CDC came out with their revision of these recommendations in 2022 with a more holistic approach, an approach that would help to make sure that we were not forgetting the adverse sequela of changing prescribing for individuals who had legacy prescriptions, and basically to say we understand the risks, but once you understand the risk, what do you do about it in order to make sure that the changes don't cause more harm than the original prescribing. One of the things that came out of that was the elimination of the DEA data waiver requirement in 2022. Those of us who have been prescribing medications for substance use disorder, specifically buprenorphine, and as you know, the data waiver, that went away. And as it went away, the bill that made that not necessary also made it incumbent on any prescriber to get 8 hours of education, once in a career education that's required that talks about these concepts that we'll be talking about today. So as all of the prescribers within your community go up for renewal of their DEA license, they're going to have to demonstrate that they've had 8 hours of training at one point in time about safe prescribing concepts and what the risks are and what have you. So that's going to be helpful with respect to gaining some traction in understanding and overcoming some of the barriers that we have with respect to the groups that you treat and the clinicians that you have that are managing these medications. The FDA has their own recommendations. And then the other thing to talk about that is that we have to remember that there's a context of state guidance documents as well. This is the plug-in for in the state of Nebraska, we have the pain guidance document, which, like our PDMP, is not just about medication, opioid medications. It also includes the kinds of medications that we'll be talking about today. And I would encourage you to possibly review that document because we have chapters on special populations, including the elderly and other medical illnesses, and it includes all of the medications that we're talking about. So really, we've got a lot of momentum that's created by these changes on a federal level more than anything. And so hopefully what that's going to do is it's going to put a little spotlight on what's best practice and more importantly, why best practice is what it is. So it will help us to make kind of buffer any problems that we've experienced. Interesting thing about this is really fundamentally the guidelines for as it relates to the opioids and benzodiazepines and what have you is, they have different categories. It's basically what's safe, when do you want to initiate these kinds of medications, and specifically when do you not, with respect to comorbidities that might be present that would want to point us towards a different direction. And then also understanding of what the dosages and what the risks are associated with the dosages and so forth. And then how long we're going to be prescribing these medications, as well as what's the risk benefit ratio of these medications. So they have really 5 guiding principles with respect to when we're prescribing and when we should not be prescribing. Again, these are specific to opioids, as you'll see, but they're not the kinds of guidelines that aren't translatable into populations with specific risks, elderly, those with medical illnesses and what have you. Subacute chronic pain. So subacute and acute illness is it differently entirely than chronic disease management. And that's true with respect to opioids. It's true with respect to medications like sedative hypnotics, like muscle relaxants. It's true for benzodiazepines, and it's certainly true for any of the agents that are anticholinergic, where medications that are effective in the long run are frequently more difficult upon initiation, and those medications which were helpful at the beginning are oftentimes not sustainable. So you get a different type of risk upon initiation than you'll get in the long run. The other thing that we always have to talk about is that these are all voluntary recommendations in these guidelines. And so whenever we're working in this space, we have to understand that none of this is intended to replace good clinical judgment. So that creates a real dichotomy where we understand what best practice is, and yet we have different interpretation of best practices with all of your different providers and a different understanding of the risk benefit ratio, and how do we navigate that space where we preserve autonomy and integrity of prescribers, as well as across the different specialties. Multimodal, multidisciplinary approach is important for management of these conditions. It gives us better outcomes, as you know, but it also gives us specific risks, and that becomes a question of when 2 different kinds of medications have augmenting or synergistic adverse effects, and they're being prescribed by different teams. How do we navigate that? Who's the kind of linchpin to understand how we avoid problematic use and how we avoid one prescribers' treatment from interfering adversely with another's. The other thing that we want to talk about is that we don't want to throw the baby out with the bathwater. That is the misapplication of recommendations, and so much of the time in my clinical experience, we can find individuals who are well-meaning and doing a very good job with respect to reducing risk for an individual and coming up with a prescribing pattern that's more in line with recommendations, but an individual may be in a situation where it's prudent or important maybe to go outside of the recommendations for reasons of management, end of life care, palliative care, and what have you. And so understanding that misapplication of recommendations, because these recommendations aren't intended as a replacement for solid clinical judgment. So I guess that comes down, we've been talking now, that comes down to doing whatever we can to make sure that everyone understands the concepts and the risks associated so that they can communicate when it's a good idea to go outside of the recommendations for a unique clinical scenario. And then the other part about this, and I think we need to be aware of this, is the real attention to racial, cultural, socioeconomic biases in how we manage our patients. And there's been just a disheartening amount of data that suggests that socioeconomically disadvantaged individuals get the kind of care that's either less beneficial, less helpful, or more problematic, and that's for all the reasons that we know. But it's incumbent upon us to make those things better. So, with that in mind, I'm going to go through the recommendations as they relate to the specific CDC opioid guidelines, the safe prescribing recommendations, and what I would like to do is speak to the specific idea of why that's important for opioid management. But I also like to say, hey, when we're talking about muscle relaxants, when we're talking about Z drugs, we're talking about anticholinergic drugs, all those that have similar adverse sequelae. This is what's similar with those classes, because the same approach can and should be used as much as possible for all of the agents that are potentially problematic within your population. So one thing we need to recommend, and we talk about in the pain guidance document, they talk about that. Remember that non-opioid therapies are at least as effective of opioid management for many common acute pain, and non-pharmacologic agents are always important to include. That's obviously important in the pain management world, but I think what it speaks to with respect to all of the potential adverse effects that we can develop with the other kinds of medications is that we have to remember that our medications are very effective in many instances, but they're also incompletely effective, right? So most of the time when we're finding individuals who have had an adverse event, they've had medication complications and co-administration complications, it's probably because clinicians, for one reason or another, have been motivated to push medication or prescribing beyond the capabilities of the various agents. And so we're getting to a point where we're getting diminishing return with the therapeutic advantage, but we're still facing kind of mounting side effects, adverse effects, and comorbidities. So I guess the recommendation one is remind ourselves that we're only able to sometimes partially affect in the fashion that we want to. And this is, one of the ways that this is particularly important is, the damage that was done with the concept of pain as a fifth vital sign. And if an individual has an unreasonable expectation about outcomes, whether it's the fact that they can't be pain-free after a major surgery, or very frequently in our environment where an individual who has a challenge with sleep and can't sleep chronically as a manifestation of mental illness, mood disorder, depression, anxiety, or side effects of other medications, it becomes dangerous if we try to manage that pharmacologically, if we're not thinking about the adverse effects of various prescribing habits. Recommendation two, effectively what this says is in individuals for chronic management, opioids aren't preferred therapy, and non-opioid therapies are more beneficial. This is a discussion that we have in different contexts all of the time, but what we have discovered over the course of the last 20 years through pain of hundreds of thousands of Americans inadvertently dying from prior prescribing is that opioids are fundamentally not as effective as people believe in a chronic setting. All kinds of data shows that there are most effective pain treatment for severe acute pain, trauma, postoperative pain in many instances, but that in a chronic fashion, they lose effectiveness. And what this also means with respect to the other kinds of situations that you'll be facing in an inpatient setting or in a chronic care setting is that the benefits will begin to wane over time, somewhere between 8 to 12 weeks, probably, and 24 and 36 weeks, undoubtedly. The beneficial effects of managing patients not only with opioids for chronic pain, but benzodiazepines for the kinds of things, sleep disturbance and anxiety and what have you. Those medications lose their benefit, and so we naturally titrate upwards if we're not thinking about that. And what all of our data shows is that's an ineffective way to manage this situation. And as a result, individuals get mounting risks associated with diminished therapeutic benefit. So reminding ourselves that medications that work acutely don't necessarily work in a chronic fashion. And so preventing that from happening is what we want to do. And once it does occur, finding a way to unwind that in a rational fashion is important as well, but of course, always more difficult. Recommendation number 3, this is about opioid therapy, starting opioid therapy for any kind of chronic pain condition. We want to provide immediate release opioids instead of extended release opioids. This is particular to opioids, of course, but what we understand is the problem is that individuals have a very difficult time understanding how medications can stack upon themselves. And that's where a lot of the opioid deaths from postoperative prescribing occurred. Individuals, surgeons, perioperative team would manage patients with postoperative painful conditions with extended release medications, which of course led to sequela. How do we do that with medications that are not opioid related? We have to remind ourselves that the other aspect of this is that the toxic metabolites of medications, the metabolites of these medications outweigh or outlast rather the beneficial effect. So when we're using medications chronically and we're stacking medications on themselves, what's potentially an adverse effect may become accentuated over time as an individual becomes attenuated. Recommendation number 4 with respect to opioids is understanding that opioid naive patients need to have their medications prescribed at the lowest effective dose. That represents a challenge for us when we've got order sets and when we're using medication, a checklist of medications in hospitalizations where you can checklist, one medication for mild to moderate pain, one medication for severe pain, and another medication for even more severe pain, and then sleep. And if we're checking all of those and we're not taking time to assess at appropriate intervals, we'll develop stacking risks associated with prescribing. Again, the challenge is in an environment where you have elderly patients who can't easily communicate, not that, but also staffing levels, challenges with respect to coverage and what have you, gives patients a lot of risk. Recommendation number 5, people who are already receiving opioid therapy should consider the risk-benefit ratio of increasing or escalating. This one I think is very important, and not just understanding risk of opioids, but other agents. What this tells us, and our literature in the pain field is very specific, and it tells us that if an individual is managed over time with, for example, 25 MME of opioids for a chronic pain condition of whatever sort, if they begin to lose benefit at lower doses, our data shows when we really closely look, so what we do is naturally we upwards titrate. We say they're metabolizing the medications differently. We say that they're becoming tolerant and what have you. But when you fundamentally look at that, what our research has shown is that the physiology changes with time. And that means if somebody's managed effectively at low dose of a medication, an opioid, a benzodiazepine, a sleep agent, if they're managed with low dose for some time and they begin to lose efficacy or become what we think of as tolerant, what's really going on is that the body is adapted and the physiology hasn't changed in a way that means that higher dose titration will only work for a very short period of time. And then it begins to lose its effect at the higher dose that it was losing at its lower dose. And the problem with that is that the beneficial effects, the therapeutic advantage is not sustainable in those kinds of medications, but the adverse effects become stackable. That is, the adverse effects of a higher dose of the medication, even if it's not working. So you'll see benzodiazepines and opioids shouldn't be co-prescribed. That's because as an individual loses the therapeutic advantage and they get that increasingly titrated, the synergistic effect on respiratory suppression is maintained. So you lose the benefit and you gain kind of increasingly adverse effects. And so one of the concepts of safe prescribing is if a little bit isn't working anymore, a lot won't eventually either. So we need to come up with different strategies rather than just titrating upwards. So maybe the idea here is to avoid the idea that we're getting tolerant to a medication and finding different pathways to interrupt the problem. Recommendation number 6 is, again, going to be specific to an outpatient setting, and that is if you're prescribing individuals, don't give them more than they can than they need. And that's really, as it relates to this environment, is just trying not to put medications with potential adverse effects out into the environment where they're going to be not something that you will be managing. Certainly doesn't have as much to do with inpatient settings. But what we do know, and something I can speak to on this, is one of the risks that we should be aware of is the idea of diversion. We think of diversion as individuals who are being, trying to break the law or selling medications. But what we know is the great majority of diversion is within family members and friends who are moving medications around in an attempt to regain therapy or provide therapy in a setting that's probably not best. So part of what we need to be doing is thinking about the risks associated with the use of that outside of an inpatient setting. The next concept with respect to opioids is that most of the time opioids are going to work for a short period of time, and they're not going to continue to work. This is what I talked about earlier. But the same is true. The same is true for the other agents. Using them for a short period of time may be effective, but adding them to the medication list, especially as these individuals go into step down facilities or out into the community, what you're going to get is a gradual erosion of therapy and benefit while you get maintenance of the risks associated with it. So it may be working in the inpatient setting, but let's be careful about how we move into the community with these medications, and they're not going to continue to provide benefit with individuals who maybe aren't supervised as much as they were in an inpatient setting. We need to understand what the harms are associated with these, and understanding the risk associated with this. This is obviously specific with respect to naloxone, having that available to reverse opioid poisoning. But much of what we have to do is in this day and age, you as vigilant as you are going to be, you're not going to be able to prevent the adverse effects outside of your sight, outside of your supervision. So this is a with respect to safe prescribing, it's a plea for as much education, understanding the comorbid risks of medications, and evaluating the potential for harms. What this also means is that a very under-recognized subset of individuals are subtly misusing medications, right? We tend to stigmatize individuals who are misusing medications as somebody that is unique, but remind ourselves, we're well aware of the fact that, for example, in Nebraska, alcohol is the substance that's most commonly misused. Binge drinking is as high in Nebraska as anywhere in the United States, and alcohol use disorder is very high relative to the rest of the country. And that means that we have an underrepresented understanding of individuals who misuse prescription medications as well. So when you see an individual taking more medications than prescribed, asking for medications and dose escalations and all of the aberrant use patterns that you see, don't be afraid to put on a different part of your brain that says maybe something else is going on here, but therapeutic use. And the earlier we do that and we change the prescribing patterns, the more likely we are to make a successful difference in the management of these patients. Recommendation number 9 is to use the state PDMP data. And as we get into that, the thing that I'm going to say 2 things about this that I think are critically important for the state of Nebraska. And the first and foremost is that the PDMP in Nebraska was we were one of the last states to get a prescription drug monitoring program. In exchange for being the laggards with respect to getting it through the legislature, which was a challenge, we got a prescription drug monitoring program that is fantastic. It's much better than most other states have. And why is that? It's because it includes all medications that are dispensed, and all pharmacies and all clinicians must be integrated into this. What does that mean? It's the perfect answer for MedRec. You can do reconciliation from the PDMP and you know precisely what's been prescribed, not just medications of opioids or benzodiazepines, but all medications that have problems with anticholinergic effects, combinations of antidepressants that may have serotonin effects and what have you. You have access to real-time accurate data about what's prescribed. The caveat, of course, is that individuals live across state lines. They can go to pharmacies across state lines. So it's not perfect, but it's much better than it is in most locations. And they're doing a better job all the time connecting the different PDMP platforms so that you can get data from other states. The next thing I'll say about that is you're going to have a hard time getting your clinicians to consistently use that. We know that despite the fact that something like 98% of pharmacies are reporting correctly, it's a minority of clinicians who use the PDMP on an appropriate day-to-day basis. But we can fix that, and you can help with this. And the way you can do that is you can any licensee of HHS, any licensed provider in the state can get access on behalf of a clinician for the PDMP data. So most of you would know that if you're working with APPs or providers and you say, hey, we're frequently working together on the floor, you can access on behalf of one of those providers and you can get access to the PDMP data, which is very helpful. And you can do that in behalf of the providers. And the other point about this is that a real push has been and should continue to be within all of our environments is single sign-on. What that means is when you're in your own facilities EMR, by logging into the EMR, the appropriate individuals with the license and the who have signed up and become registered with the PDMP can hit the button, and you've got MedRec done based on the PDMP with the push of a single button. So if you want to do something that makes a difference in your own facility, start the process of advocating for single sign-on It's just an investment in time and a little bit of money sometimes, but mostly time and energy in terms of getting that logged in so that you're connected if you're not already. Recommendation number 10, toxicology testing, understanding what that relates to and using that effectively. I'm going to say a few points about that because you're going to know that that's specific to opioids and other controlled substances and what have you. But remind ourselves that there are multiple metabolites of these medications that are effective with or have effects with respect to adverse effects that outlive the therapeutic advantage. So making sure you understand what individuals are taking, how that relates to side effects and what have you. And then the other part of that should be understanding end organ function. So part of toxicology screening is, do these people have appropriate renal and or hepatic functioning to clear these agents in a fashion that doesn't put them at increased risks? And as you know, many of your individuals are not effectively able to metabolize agents as you would wish. So now we're going to get into, this is where we kind of get into some of the part I think that you're going to be particularly interested in with respect to elderly population, medically frail population. One of the biggest problems that has been faced with respect to the CDC regulations is the big focus on the fact that opioids cause respiratory suppression in a dose-dependent fashion over time. We know this, so you can give somebody fentanyl or hydrocodone or morphine until their respirations slow down and they stop breathing. What's not fully appreciated, however, is the magnitude of the adverse effect of combining that kind of a medication with another medication. Give you an understanding of the magnitude of this. If an individual is given relatively low risk opioid prescribing, you can say 30 MME or less, which is common prescribing. Somebody's maybe getting 7.5 milligrams of hydrocodone 3 times a day. If you add a benzodiazepine, or if somebody adds Ambien or a sleep agent, you increase the respiratory suppression and risk of respiratory arrest fivefold, 500%. So what happens is individuals that are technically in a class by class basis being prescribed safely, when you add another agent in a different class, then you have a great increase in the risk of the prescribing in this fashion. So that becomes a major challenge, especially as we have lack of cohesive care. We have different specialists prescribing in different areas, and then the challenges that face trying to find out who's going to be prescribing for who. The other additional association with this is that many times patients don't understand this correlation. So they think that if any individual is prescribing in a safe fashion, then everybody else is prescribing in a safe fashion as well, when it's the interspace between the different services, the different specialties, the different providers that creates the risk associated with the patient. And how we manage that is important, and that's probably why you guys are sitting in this talk in the middle of the afternoon on a Tuesday afternoon. But that magnitude of that is really not appreciated. And in my chair as a clinician, I can't tell you how high the percentage is of patients who are concerned about, I don't want to be put on more, pain medication, for example, but they haven't appreciated the fact that once we've added anticholinergic agent, a sedating, a muscle relaxant, and maybe a sleep aid, those portions of the prescribing is much more dangerous than the other portion, and the combination is extraordinarily dangerous. So it's that gray area between prescribing that represents our particular risk. This basically is a slide about treating patients who've developed problematic use patterns, but what it reflects in this environment is the idea that we don't have the open conversation. We talk very extensively in our training about the art of the difficult conversation, and we don't enter that conversation for a number of reasons. But if an individual is developing problematic use patterns, or an individual is developing side effects from treatment that maybe started out rational, but it's losing its benefit with respect to the risks, then the person who is most likely to make a difference is the person in front of the patient right then and there. And if you're comfortable with your relationship with the patient and having that discussion, leveraging your therapeutic relationship with the patient is important. And the challenges are there, of course, when you've got different services and in sort of parallel fashion managing patients. But understanding the risk of overdose, the risk of problematic use, the risk of developing psychological dependence as well as physiological dependence is really something we should not shy away from, and we should be confident in making important steps to change prescribing when necessary. So that's going through the safe prescribed guidelines. Congratulations, you all get an hour credit for a CME that helps you if you're going to get your DEA license renewed, and now you just need 7 more hours for that. But what you want to think about, and what you're specifically interested in, as I understand it, is how do we manage elderly patients with a particular set of risks, and how do we prevent them from being harmed by what we're doing, right? And understanding why these individuals can be harmed and may have problematic use is a pretty big topic. So I tried to find a way to organize that to sort of help you think about what to do. And it's obviously beyond the scope to say, well, hey, don't give somebody nortriptyline instead of zipramine. Don't give somebody this agent that's got more norepinephrine effect than this one. Those are all challenges, but understanding why they're risky and how, in a practical fashion, these individuals run into trouble is probably something that we can address in a lot of time. The first thing is that individuals with particular risks are exactly the individuals that are likely to be prescribed, right? Individuals, as we age, as we have metabolic changes, as we have musculoskeletal changes, for those of you who are wondering, a bird just hit the window right here. Individuals have need for being prescribed, right? As we get more frail, we need more help, and pharmacologic help puts these people in the risk of harm. But what goes on to make it more challenging for these patients is pretty clear. First, altered metabolism. Individuals get a gradual decrease in metabolic functioning as they age and as diseases step in. Most of the systems in the body, we will always learn, have a 10 times redundant capability. So somebody can develop breathing abnormalities, they can develop COPD, and it's not until they have loss of 90% of their alveolar function before they get short of breath with emphysema, right? Same is true with renal function. We can metabolize agents for a long time with altered renal function, but at some point that becomes critically problematic. So the altered metabolism of these individuals accentuates the potential accumulation of the adverse effects of these medications. The same is true with altered neurologic functioning. I encourage our patients to think of their neurologic functioning not as a series of electrical wires that are interconnected, but rather as a computer network that's interconnected. And as that computer becomes more and more affected by viral attacks, it's more likely that any single problem is going to affect function. So accentuation of the neurologic deficits accumulates in individuals, whether they're developing memory difficulties, whether they're developing challenges with respect to neuropathy, whether they're developing changes in their nerves and their sympathetic tone so that they can't accommodate for small changes in orthostasis and what have you, alters those functions, and that certainly makes them more likely to develop adverse effects. Cardiovascular reserves are diminished as well. Many of these agents preserve cardiac, aren't really directly affecting cardiac function, but a lot of them affect vascular function. So you can get orthostasis, you can get a hypotension, you can get falls that result from that and altered function. And that's true for many of the different agents that you see. So that's a big challenge. And then the other thing is important is their reduced exposure, the reduced availability of all the external things that we take for granted that individuals have to prevent problems. That is possibly their living arrangements, possibly their ability to communicate altered function, and really probably is a little bit our bias, right? We kind of aren't always listening to some of the subtle changes before they become problematic. I want to talk about some of the particular agents that can be problematic for individuals and what the associated risks with these are, and what we need to be thinking about when we're seeing individuals with these. The one that I think we really should point out that probably gets much less attention in our day and age are benzodiazepines. Benzodiazepines we use ubiquitously, and when you look at the data on benzodiazepines, it's really unequivocal that benzodiazepines are helpful in an acute setting and very difficult to wean away from in a chronic setting. Benzodiazepines really create a lot of long-term problems, and much more so than opioids. Other than respiratory suppression, the benzodiazepine use can be very problematic in elderly patients. We understand that benzodiazepine use changes memory function, right? You understand that benzodiazepines are inherently amnestic. They create memory loss problems that can be associated with changes in ability to be oriented and problems with cognition as well. What a lot of people don't understand is that with chronic use at appropriate doses, opioids, even in elderly patients, preserve cognition. They don't have sedation over time as frequently, and balance, coordination is generally preserved with chronic use with opioids. There's issues with respect to respiratory suppression that are very important, and there's issues with respect to development of opioid dependence that are very important. But an individual who is using stable doses of opioids, you can measure, and we should measure, you can measure good function preserved over time. That is not ever true with benzodiazepines. Almost in a dose-dependent fashion and almost invariably across all kinds of individuals who are being prescribed benzodiazepines, you get an alteration in memory, an alteration in cognition, and an alteration in psychomotor function. An individual who is being chronically prescribed Pickett, Ativan, clonazepam, Valium, those kinds of agents, has a very difficult time preserving motor function, psychomotor function. And there's a question about individuals taking these medications over time, whether they're fit to be driving and functioning machinery and what have you. So be aware of the fact that chronic use of benzodiazepines is in an ongoing fashion very likely to create changes that are negative with respect to chronic use. And the other part about benzodiazepine use is that if an individual has been prescribed benzodiazepines chronically, it is exceedingly difficult to wean them away. It's a process that has to be done very slowly. you will undoubtedly negatively affect sleep in a way that you can't reverse, and that has its own set of circumstances. So the recommendations really are avoid chronic benzodiazepine prescribing and do whatever you can to prevent individuals from becoming impaired over time with this. The next one I'd want to talk about with this is muscle relaxants. Most of the time, we probably shouldn't label muscle relaxants as muscle relaxants. There's a few that have specific muscle relaxant effect. Baclofen comes to mind, but almost all of the muscle relaxants primarily exert their effect by affecting the central nervous system function, and they're really sedative hypnotics. We got away from a lot of the barbiturates over time. You don't see people being prescribed barbiturates for chronic migraine headaches over time, but we still have a problem prescribing individuals muscle relaxants in a chronic fashion. That's particularly problematic. One of the things that we spend a lot of time educating when we have residents and fellows and students and what have you is that, for example, chronic pain is really not a muscular condition. Very few chronic pain conditions involve dystonia or muscle spasm. Most of the time, what individuals feel as muscle spasm is really altered nerve functioning that's leading to altered functioning of the muscle. So muscle relaxants generally primarily exert their therapeutic effect by taking advantage of the side effects, which are sedation and drowsiness and overall relaxation. That is a problem in the elderly patients and patients with comorbid medical diseases. We, as a matter of recommendation, muscle relaxants should not be co-prescribed with opioids and should not be co-prescribed with benzodiazepines. And even individually, muscle relaxants should not be prescribed chronically for individuals. And that's probably something where there's a little bit of controversy with that. It's certainly different than what we're doing, but there's a lot of data that shows that over time, co-prescribing muscle relaxants with other agents is particularly problematic. In our world, we've known for decades that what we describe as the holy trinity is Xanax, Soma, and hydrocodone. Those three in combination almost are pathognomonic for development of use disorder and adverse effects associated with decreased function. So be very careful about prescribing muscle relaxants and benzodiazepines in individuals. These are going to be the medications that cause problems in individuals who are being rationally prescribed medications, for example, for pain. The other one are Z drugs, sleep aids, almost universally misprescribed in many instances. Remind yourself that there is really no data that says sleep hygiene is well managed over time with Ambien, Lunesta. All of those medications are not intended for chronic use. And so when you have an individual who has a difficult time with sleep hygiene for all the other medical reasons that are beyond the scope of talking about today, if you're going to start that individual on a sleep aid or a Z drug, what is your plan to back that out? Because we understand that over time, co-prescribing or continually prescribing Z drugs is very much like benzodiazepines. They're very closely related agents. And so what they do is they impair cognition, they impair psychomotor function, they impair memory, they cause disorientation, and they cause orthostasis, and that's ongoing. And over time, they fundamentally don't improve sleep architecture. They just sedate somebody so that they get some sleep in a short-term fashion. So you really create problems if you're prescribing these in a long-term fashion, and understanding that they're not intended for long-term use is probably something that we need to work on as a medical industry. The next concept, of course, is antihistamines. Most of the time when we're developing problems in I have so many friends who, who tell me they can't sleep at night, so they just take, a little bit of Tylenol PM, which is, as we know, just Benadryl and Tylenol. So they're just basically misusing the adverse effects of antihistamines, but antihistamines to a lesser degree, but to the same in the same fashion, create long-term problems with development of changes that are going to put our patients at risk. And why do these agents in combination in particular put these patients at risk? It's because they interfere in a kind of an additive or synergistic fashion with multiple systems, right? These benzodiazepines work by changing limbic system activity, and they work by detuning the brain and causing changes in the hippocampal area, which is memory formation and what have you. So they accentuate neurologic deterioration in an ongoing fashion. Cardiovascular, these agents create orthostasis because of their changes in vascular tone, as well as neurologic functioning. Cardiovascular, orthostasis is the enemy, right? Falls, confusion, dizziness, lightheadedness, and all those things. From a musculoskeletal standpoint, the muscle relaxants are detuning the muscles, right? They're not doing it specifically for the one muscle that's sore. They're doing it for all the muscles, and that leads individuals to develop problems. And of course, this all creates problems with executive functioning, and individuals who have challenges with respect to that. We have to be very careful about making that worse for these individuals. So how do we address this? You guys, anyone who's listening to this talk today, you want to be part of the solution. You want to find ways to make resilience, and you've been involved in multiple processes to make that better, and sitting on stewardship committees, sitting on committees with the hospital, seeing all the problems that can develop. What do we see? Alignment, right? That's our challenge in healthcare in 2023 and in the future. How do we align all the different individuals in a fashion that doesn't just interfere with our day needlessly, but rather allows us to work together as a team? So we mentioned med reconciliation, repeatedly, continually working on med reconciliation. I again would make my plug for the PDMP, making sure that we're doing that, understanding that most of the problems aren't with a single agent. They're a problem with combination of agents, and oftentimes combination of agents prescribed by various teams that are not directly communicating as well as they might in an earlier time. Understanding the various provider roles and the fact that the fragmentation of care is a particular challenge, and everybody lives in their own sandbox, of course, but if we can define who's looking at what, making sure that everybody understands the relative impact of their particular risk and working together to reduce that. Of course, that has to be facilitate communication and reduce barriers to change. I think the best way to do that is through education and through an understanding of why. I think generally that's something that individuals are willing to work on, as long as they understand why change is necessary. And I'm willing to bet that anyone who's sitting on this Zoom meeting in the middle of the afternoon is part of the solution rather than part of the problem. So thanks, guys. Can I answer any questions? I know that's a big survey of a large topic, and I probably missed a lot of stuff you wanted to hear.
Thank you very much, Dr. Massey. That was a great presentation. Does anybody have any questions? Either unmute yourself, or if you want to type into the chat. And we just got a couple minutes left. Like we said, this presentation is recorded. We'll make sure you guys all have the link. Otherwise, if there's nothing coming across the chat, give you guys a couple minutes back of your day. But thank you again, Dr. Massey. That was a great presentation. We really appreciate it. And for everybody else, we will be getting the links out to you and going from there. So thank you all very much and have a good day.